Good afternoon, everyone. I'm Katie Moore with the Virginia Funders Network, and we're so glad that you've all joined us here today for the first Health Funders Networking Group session of 2022. We have a really great topic today. Before we get started, I just wanted to remind everyone that Virginia Funders Network's inaugural conference is going to be May 3rd and 4th. Early bird registration is currently open and expires on March 1st. So please do make sure that you register for the conference for that $50 registration discount. And now, without further ado, I'd like to turn it over to our Health Funders Networking Group co-chair, Valerie Liggins from the Cameron Foundation. Valerie?
We're really glad to have you here today for our panel, which will be looking at behavioral health and the landscape of mental health. And so we have some really great panelists. And so first of all, I'd like to start it out with introducing our moderator for this session. Debbie Oswell has served as Deputy Secretary in the Bolling and Wilder administrations in Health and Human Resources. That's really impressive. In 1992, she became the founding director of the Virginia Healthcare Foundation. And the Virginia Healthcare Foundation was created as a public and private partnership by the Virginia General Assembly and its Joint Commission of Healthcare. The mission of Virginia Healthcare Foundation is to increase access to primary health care for uninsured and medically underserved Virginians via innovative programming and service delivery models. Under her leadership, they have developed several edge initiatives which have been instrumental in significantly expanding the scope of health services and access to treatment for more than 800,000 uninsured Virginians. We are pleased to have Debbie agree to moderate the panel discussion today, and I will now turn the session over to her capable hands.
Thank you very much, Valerie, and hello to everyone. It's really great to see you as much as you can see anybody on Zoom today. I think this is going to be a great session, and my job is a very important one. It's to keep us moving along and to introduce the speakers. And so we're trying to be right on time, and we're going to move right to introducing Heidi Dix, who has worn many hats over the years, all of which make her a perfect person to present to us today on the behavioral health landscape. Heidi recently moved to the Virginia Association of Health Plans, and forgive me, Heidi, I can't remember the exact title, but she does a lot of government relations work with the association, among other things. And immediately prior to that, Heidi was the government affairs person at the Virginia Department of Behavioral Health and Developmental Services for 6 or 7 years, maybe, Heidi, for long enough to know what's going on in the world of behavioral health. We're eager to hear from you.
Thank you, Debbie. Before I dive too deep into here, I do work for the Association of Health Plans. We do have an important role in Virginia in providing healthcare coverage to folks. So I just wanted to touch base on our organization. We represent many health plans that do business in Virginia, both in the commercial market as well as the Medicaid managed care market and the individual marketplace. And so just to briefly, and just to remind people, we provide a lot of coverage to folks through Medicaid managed care, almost 2 million enrollees. And then about 24% of Virginians are under sort of a state regulated framework that we do a lot of advocacy for. Just a snapshot of kind of who we're representing in Virginia. So I was asked to really look at talk about the behavioral health landscape. So I wanted to just start with a reframe. I know you all are very well informed folks. You read the paper, you watch the news, you keep track of various organizations and things that provide information to you on a daily basis about what's happened during the pandemic. And so you are certainly aware that there are so many studies that have shown the adverse impact of the pandemic and the increase in behavioral health needs that we've seen across the board. So nationally, I'll get to Virginia in a second. there are many more individuals reporting symptoms of anxiety or depressive disorders, suicidal ideation. We've seen a huge increase, unfortunately, in drug overdose deaths. We were doing really well nationally, and in particular in Virginia before the pandemic, in reducing the number of overdoses and fatal overdoses. And unfortunately, that has just skyrocketed since the beginning of the pandemic, and it hasn't slowed down. And that's, really upsetting to see. I think the other thing that you're all aware of, and shouldn't be news, is that pandemic has had a disproportionate impact on racial and ethnic minorities. And certainly there's been the experience of many more Black Americans and Hispanic Americans experiencing more of these concerns and conditions, sometimes with less access to care. So just nationally, that's what is occurring. I thought this particular factoid was compelling. I think folks need to keep in mind that a lot of the studies that we read about and hear about on the news talk about increased needs, and yes, needs are skyrocketing. And I think what I want folks to understand is that hopefully this is the tip of the iceberg, meaning as the pandemic is hopefully subsiding, we're not going to see these needs continue to increase, but they're going to be with us for years and years. This is going to have a lasting effect on our society and in the world for a very long time. And I just want to point out, when we say behavioral health need, for framing of this, we're really talking about folks that may need support during a crisis. They may even require inpatient hospitalization. It also can mean psychotherapy to deal with the anxiety people are experiencing, or depression. It can mean medication-assisted treatment for opioid addiction or other addiction, and many other longer-term sort of psychosocial services. So it's a wide swath of things that people need to support them in their communities and help them to lead successful lives. And we're seeing needs increase in all of those categories. This is just another slide that shows nationally. I didn't have time to stick a label on this, but this is from the MMWR, which is a public health publication from the CDC. This is pediatric ED visits. This is just from January of 2020 through October of 2020. And you can see the dotted line shows the proportion of ED visits that are related to mental health and what transpired during that year. And that trend really hasn't abated very much. And so we're in a crisis for adults, but I think for kids, it's even more significant. And we really have to start thinking creatively about how we're going to support those kids going forward. And it goes all the way from kids age 5 or younger to young adults and the experience they've had during the last 2 years. So that's sort of the landscape in the pandemic right now. When you think about this and you take a moment to think about the behavioral health workforce we have nationally and in Virginia, it's quite, it can be quite depressing to think about. We are definitely in a national crisis. We have organizations that are truly having trouble recruiting and retaining employees. Just trying to get enough applicants to even apply for a position, let alone a qualified applicant, is extremely challenging for some of these jobs. I'll talk a minute about why. Many of these providers are reimbursed through the Medicaid program, a significant number, or other public payer programs. And so if you don't increase the rates that those providers pay, they can't increase their salaries to recruit and be competitive. Many people are burned out from COVID-19. We've all heard about that. Healthcare workers in general, certainly behavioral health is no exception. And then there's also a demand for higher and higher sort of skilled professionals to enter this profession and deliver services. And of course, when you have a need for higher skilled professionals, you need to create them, and they're not always there. So we're sort of in a conundrum nationally. And then, as for those of you who are very familiar with Virginia Healthcare Foundation, Virginia's behavioral health workforce is no exception. Debbie and her team put out an amazing report this January that really has has highlighted the deep need that we have in Virginia for the behavioral health workforce. So these are some statistics that come directly from the report, where she and her team assess the capacity of the licensed behavioral health workforce. I have some notes here, but really, when you look across Virginia, 38 states have more licensed folks than we do. We are 39 in terms of access. I think something that's really quite striking is that we have I would say almost a majority of Virginians that live in localities where there's a mental health professional shortage area. And if you look at some of the statistics and maps in the report, it really shows it's very striking. You have a concentration of professionals in some of the more urban areas like Richmond and Northern Virginia, and then very few services elsewhere. In some areas, no services. Meanwhile, when I was at the department, we had many health systems and hospitals coming to visit with us and talking about how they had done community needs assessments, and behavioral health services was a top ranking concern among folks in their community, businesses, schools, citizens, and wanting to partner with us to find solutions. I also want to point out, this is also from the Healthcare Foundation's wonderful report, and I've sort of put my own spin on it, but this is not a new crisis in Virginia, probably, or elsewhere. Behavioral health work is tough work. It's sometimes you're working with difficult folks. They can be challenging, especially if you're an unskilled person that's interested in behavioral health. So you have a 4-year degree and you want to go out and work and get experience to become licensed. You're doing some really tough, direct person-to-person face work that can be very, very difficult. There's also a really high bar to entry for a lot of folks, particularly as you go, folks that are just recent graduates or people who are just starting in the profession. You have to do a background check and do all of these other things to even be able to work with individuals face-to-face. And you can go down the street and get a job elsewhere where you don't have those kind of barriers to employment. So those kind of things can really prohibit folks from joining the profession. And then there's just a lot of administrative burden, paperwork, whatever you want to call it. There's a huge regulatory structure that overlays a lot of how we provide services in Virginia, and it can really impair people being able to work directly with folks one-to-one. And so these are all near-term problems. Some of them we could probably fix pretty quickly, like increasing salaries, right? Or, encouraging folks to provide services in more rural areas. Some of the challenges are related to broadband and telehealth. How could we do that? To me, I think those are things we could work on very quickly in Virginia. I think longer term, the pipeline of professionals, which is really a large part of what the Healthcare Foundation report covers as well, is not large enough.
Oh, you're good.
Not large enough.
Right there.
Okay. Bye.
So we need to really think about how we increase the pipeline of professionals that are coming into this profession. There are ways to do that, but the results are not short term. It's going to take years to get those folks on board and really contribute. So just a few more points I want to raise here. So in addition to having a behavioral health workforce crisis and our needs skyrocketing in the behavioral health space, we also have something else coming up. And I just want to note it for folks. This is really important for you all to understand because it does impact many, many Virginians. During the federal public health emergency, which we're still operating under parts of it, people could apply and enroll in Medicaid and became eligible and receiving services, but they were not disenrolled. They didn't have to do eligibility redeterminations or anything like that. So we've seen an unprecedented increase in enrollment in Medicaid. We have almost 2 million residents enrolled in Medicaid, which is wonderful. The federal public health emergency is going to expire at some point, probably in the next 6 months. And then the Medicaid agency in Virginia has to begin a very complex process of unwinding. And people will be redetermined for eligibility. And some people will, many people, could be quite a few, will not be eligible anymore. And, there's a burden on all of us to make sure those folks can retain either their Medicaid coverage by completing the renewal process or ensure that they are, at least offered the opportunity to enroll in the marketplace for an individual plan, which is still very highly subsidized. So there's a lot of work to be done in this area. Not a lot of people have been talking about it until recently, but I feel like it's really important because a lot of folks get their behavioral health services through Medicaid, and we could have a lot of folks losing coverage. Very disruptive. There's a couple other key pillars before I get to the crisis piece. Go ahead.
Heidi, I'm going to just give you a 1-minute warning.
Okay. So we have 3 key pillars here of behavioral health initiatives that are underway. They're really critical to sustaining a continuum of services to keep people out of hospitals and out of crisis. And we have the recent launch of our crisis system in Virginia. And this has 4 key elements that you can see here. And I think what's really important to understand is that the 988 legislation will, the phone number will kick in this summer. And that will be directed to these high-tech crisis call centers that we just initiated last month. And we're still very much constructing here in Virginia. But these are essential pieces that we need in our system and we need to continue to push for. So where do we go from here? We need to sustain that Medicaid coverage where we can for those folks coming off the public health emergency. And we need to continue to invest in our workforce with short-term and long-term solutions and work on some of these other key pillars.
Great job. And so Heidi, do you want to just comment on what's happened in the General Assembly related to our next speakers are going to talk about the Marcus alert, but do you want to just mention recent legislative action related to that?
So I'm trying to, so it's so piecemeal. So Marcus Alert passed 2 summers ago. It's a local program, and I know the folks are going to cover it. It's an important pillar of the crisis system that we're putting in place and allows for different kinds of responses to people in crisis that are preferred to a straight law enforcement response or another kind of response. It was funded in a piecemeal fashion. And so we have a situation now where we're putting funding in each year, the General Assembly is. And so I think the General Assembly just put in another bit of funding for 5 more sites. So I think we're up to 10 in Virginia. So you'll be hearing about them. They're very localized and specific, but they still need a base of funding from the General Assembly to kind of move forward.
And I saw that I think in the House, maybe they passed a bill that would exempt 93 of the 133 localities in Virginia from implementing that because of the costs. Have you followed that?
I have, although I thought that went away, but maybe I just dreamed that in my sleep.
Okay.
But I will say in the behavioral health space, just generally, we have a couple of sort of, I'm missing the word, but we have some other examples where like Step Virginia and other things where they have put these mandates in like Marcus Alert and Step Virginia, and then they have not fully funded them and they end up doing it piecemeal. I'm not saying that's ideal. In fact, I don't think it is, but that's certainly the approach they've been using in behavioral health for many years.
Okay. Thank you very much, Heidi. So we'll just take 1 or 2 minutes if anybody has any questions for Heidi.
I'm trying to see the chat.
Me too. I think if you have a question, we don't have that many people on here, just speak up. Make sure you're not on mute.
I'd like to ask a question. I'm Kendra Jones with Richmond Memorial Health Foundation. Thanks for putting this panel together. Really appreciate it. I saw on one of the slides where it was mentioned that the diversity with mental health professionals does not match the diversity within the state. And I'm wondering if you all have any information on BIPOC mental health professionals in the state, any numbers of how many, or a directory where one could find that information, where one may want to talk to a therapist that is a person of color to make sure that there are no cultural differences or misunderstandings when receiving therapy or help?
So I can answer that. If you look at the behavioral health assessment that we did that Heidi just mentioned, and I think I just saw it was going in the chat, there, right there will tell you, will give you the data in terms of the number and percent of each of the 5 licensed behavioral health professional types in terms of race and ethnicity. So that gives you at least a feel for how we're doing. Some were a little closer than others. I think maybe licensed professional counselors get the closest to meeting proportionality of the population, but it's lacking everywhere, really. I can't help you with a list of people of color who are licensed behavioral health professionals. That could be, I suppose, a project someone could take on or something.
Well, I do know of one where one was started, but it's not a complete listing. So maybe someone can build on that.
Yeah, that'd be great. Thanks for the question. Any other questions? Okay, Heidi, we thank you very much. Great job, especially since you said such nice things about the Healthcare Foundation. And so moving right along, we now are going to hear from Andy Johnston and Chief Jenkins. And so Andy, as many of you already know, is the is a senior, I want to get this right, Andy, senior program officer at the PATH Foundation. And he does, he's really responsible for a lot of their behavioral health initiatives. Andy's officially knowledgeable about behavioral health because his degrees, both his bachelor's and his master's, are in psychology. So he has a leg up on a lot of the rest of us in that area. He's also spent more than 30 years working in the health and human services realm in both Loudoun County and now with the PATH Foundation and in Fauquier. And so he and Chief Jenkins have something to share with us related to what they've been doing locally as a partnership in terms of the Marcus Alert. So I'll hand it off to you guys.
All right, thanks, Debbie. And I'll kick it off a little bit here. And thank you, Heidi, because you really teed up this well with that background data. We're going to really talk about 2 things briefly, and I know our time's limited. So a little bit on Marcus Alert and a little bit on a collaborative foundation-funded effort to develop a partnership between our CSB and their staff and our law enforcement. So, and while the 2 are really closely related, they are independent initiatives. So with Marcus Alert, as Heidi said, that legislation was signed into law in November of 2020. Really, Heidi underlined it well in terms of thrown together rather quickly and with very good intentions. Marcus is named after Marcus David Peters, a 24-year-old man who graduated from VCU with honors. He was a biology teacher and was in a severe mental health crisis when police responded, and he lost his life for being shot in that situation. So Marcus Alert has been an effort to improve the response to those situations, to help law enforcement with the behavioral health needs that they have in so many situations where the presenting issue is a mental health issue. We in our area are part of the only rural and the only multi-jurisdictional pilot of the 5 in the state right now. So there's pilots in Richmond, Virginia Beach, Bristol, Prince William County, and Washington County. We cover our CSB's 5-county catchment area that is Fauquier, Rappahannock, Culpeper, Orange, and Madison. And as part of that effort, we have stakeholders meeting every 2 weeks to work on our strategy locally. A big part of it has been developing a voluntary database that mental health consumers can actually opt into, and that information would be available to dispatch. It would include even things like triggers that cause people to spiral, whatever their behavioral health issue is, family information, contact information, just things to help with some knowledge as law enforcement are preparing to engage after a 911 call. So the dispatchers would have access to that, and then they're transferring that to law enforcement as they make the call. The idea is there will be regional call centers across the state. As Heidi said, and as Debbie Oswalt said, a lot of markets is up in the air right now. This was supposed to be across the state by 2026. It's not 100% sure that that's the way it's going to play out. The opt-out that Debbie mentioned was that communities under 40,000 people might be able to opt out of this. I agree with Heidi, not sure where that's landed in the General Assembly, but may still be under discussion. So that's a little bit about Marcus Alert. I would certainly encourage you, if you're in one of the pilot communities, to learn more. It's starting to branch out into other communities as well. Related to that is our embedded crisis worker with law enforcement locally. And I have to give all the credit to the director of our CSB, Jim LaGraff, and probably even more credit to our forward-thinking Chief of Police in Culpeper, Chris Jenkins, and our former sheriff here in Fauquier, Bob Mosier. As I understand it from Chris, they were leaning on Jim LaGraff hard at our CSB to help them help people that are experiencing mental health crisis responses. So as far as the collaborative part of it, and before I turn it over to Chief Jenkins, I would just say, it was exciting for us when Jim LaGraff at our CSB approached us and said, you know, we've got a sheriff and a chief of police that really want to do something on this front. Would PATH, Culpeper Wellness Foundation, and Northern Piedmont Community Foundation come together to fund a worker to partner with law enforcement in Fauquier County and in Culpeper County? And the three foundations came together. We did $30,000 a piece at the end of 21, I believe it was, or maybe we did it in early 20, just before Marcus Alert legislation was moved forward. And I'll let Chief Jenkins tell you a little bit more about the successes we've been having with this effort. Chris?
Sure, thanks, Andy, and it's a pleasure to join such a great group of folks to talk about a lot of issues facing our communities. Special thanks to the PATH Foundation and to the Culpeper Wellness Foundation for realizing the embedded clinical worker with law enforcement was the way to go. Real quickly, and I told Andy I can get on this for about an hour, so please shut me up if I get too long-winded. But
I told him Patty would cut him off too. So
yeah.
or yeah, Debbie will jump in there quickly.
That's
One
exactly
up.
right.
Go ahead, Chris. Hurry it up.
9 minutes.
I've been duly warned. But real quickly, we attempted a Department of Criminal Justice grant a number of years ago, kind of modeling after some of the programs out in Colorado with the embedded clinical worker that goes along with law enforcement. We were not successful in that grant because we couldn't guarantee that continual funding. So we didn't like being said no to. Law enforcement was getting beat up across the country on handling mental health calls, which we do not want to do. But we are the stopgap last call for almost everything, including mental health calls. So we went to Jim LaGraff and Bob Mosier, who was sheriff then. Of course, now he's the Secretary of Public Safety in Virginia. We're looking for him to do some great things. And gave this idea, and the Community Service Board and the PATH came up with some money. We hired some folks, We actually hired one in each county originally, and it was so successful that we have added a second clinician here in Culpeper that works right in our building and rides with our folks and responds to calls. But a lot of great success stories we can tell you early on, but the real concept of this is almost a very high percent. I'd almost say 80 to 90% of the calls that we were responding to have a mental health nexus with folks. And law enforcement officers are so busy going from call to call and not really having the time, the training, the expertise to deal with these are very complex mental health issues that takes a lot of resources and navigating help for anyone is very difficult, much less someone who is sick or suffering some mental health issues. So what we have found it's able to do, and I will just echo, is that law enforcement has embraced this. I really thought one of the hurdles that we would have would be getting our uniform officers to embrace this, and that has not happened. Our folks we treat these folks as if they're one of us. We embrace them, we give them calls. So obviously, two folks can't be on 24/7, 365 days a year, but the calls that they're not on, our officers are able to refer cases to them. So some of what we have found early success is some of the chronic users of our partners in departments, or just the 911 community, the hospital community, is that this enables these folks to take on a caseload, go out, meet with them, and dive down into dealing with some of their complex issues. Maybe it's just medication. Maybe they're veterans that are entitled to benefits. And as you all know in this group, that finding help is very hard to do. But knowing where to look and the resources that are out there makes it very doable. So early success it's the greatest thing we put in police cars since computers 15 years ago. And I will tell you, it is not going away. We've had a number of other agencies reach out to us. As I was sharing with Andy earlier, and I'll shut up, is one of the concerns that I have, just like with the Marcus Alert system, is that funding and these programs are going to end up in our urban areas and not in the rural areas. As we constantly see the headlines almost daily with folks that are suffering real serious issues or ending up in the news, or in very rural communities and areas, just like we saw in a beautiful community of Bridgewater College here a couple of weeks ago. So we think it is the path forward, pardon the pun, Andy, but I think it's a path forward for law enforcement. And we have, like the Wellness Foundation came in and said, hey, what can we do? So we'd like to have 2. And I'm sure we're going to be back to Andy soon and say, we'd love to have 3. So Andy, anything else you'd like me to touch on, I'd be glad to, but we appreciate the PATH Foundation again and our Community Service Board and what we're dealing with now with some very trying times. We really are in the middle of a pandemic.
I think that's great, Chris. And if Debbie, if you think there's time for a question or two, we're
There is.
glad to ask. I saw one from Constance as far as qualifications, and I'll let you talk about the 2 in Culpeper. These are not all master's level type personnel, bachelor's level with experience and knowledge and training from the CSB. I think there's some peer aspect of this as well, but as far as the 2 you're working with, Chris, in Culpeper.
Yeah, I think, I don't think they have a lot of the licensing that maybe clinical workers have, but one of the peer support folks are also making a big impact. The issue we ran into early on was obviously folks that come within a police agency. We have federal regulations on sharing of information and things like that, as I'm sure the health field does too. So there is a certain level of background that folks have to get through to allow them to work with law enforcement. And but so far it's been a great marriage. And we also in Culpeper have the C Center. That hopefully that folks will also talk about at some point, but they are basically it's a center where folks can just go to, walk in, and eventually will be 24/7 with all kinds of peer support folks. So looking for alternatives to sort of Band-Aid. Hope I'm not stepping on feet, but a real failed mental health system in Virginia.
Okay. And while you have been talking, Chief, and frankly, congratulations on the great partnership and the work that you're doing. That's really great. I've been trying to track down what did happen to that piece of legislation. And so actually, looks like somebody fixed it up a little bit. And so now what passed the House and is now in the Senate and will be considered there is legislation that will move the deadline for localities with a population of more than 40,000 to establish Marcus alert protocols. It'll move it from this July to next July, 2023. But the good news is that for localities with a population less than 40,000, they still have to do it. They have an extra year. They have until July 2024, but they will have to, no matter the size of their population, they'll have to establish local protocols that meet the requirements that the Department of Behavioral Health puts forth, and in terms of connecting 911 and everything. False alarm. So that's great news. Does anyone else have any questions for the chief or for Andy? Don't be shy. You could all do this. Okay, thank you both. Really appreciate it. And so moving right along, now we're going to hear from Robert Bolling, and who is the CEO of ChildSavers here in Richmond, and Courtney Rice, who is the Director of Inclusion and Community Impact at the Robbins Foundation. And I have to say, and they're going to talk about a really cool, well, ChildSavers is pretty cool in and of itself, but they're going to talk about a cool thing they have going on with the schools here in Richmond for children's mental health. And I just have to say, we're very pleased to have been a funder of ChildSavers and the good work that they do, as are, I think, several others on this call in this area. And I've known Robert for at least 100 years, from back when he was, when we were both kids. And he worked for the State Health Department in a number of roles, and has then became a nonprofit leader in a number of organizations here in Richmond. And Courtney, I don't know you yet, but it's really great to have you on the call and or on the meeting, and I sure look forward to working with you. And so without further ado, let's hear from them.
Thank you. It's great to meet you, Debbie. I appreciate this time today. I should make sure, can you all hear me?
Yes.
All right. Okay, awesome. So in the spirit of time, I will look to be brief with this, but we were just ecstatic about having this opportunity to partner with ChildSavers. I do want to highlight that the way we began partnering with them or investing in this initiative was through a very non-traditional grant opportunity. It was a grant competition very similar to Shark Tank, which was affectionately referred to as the nonprofit Hunger Games. So lots of unintended consequences, lots of lessons learned through this project. But this was a huge opportunity for us to invest in both innovation and collaboration, where we were looking to solicit from organizations what was that transformative change to a complex social issue, without any concern for what that issue was, as long as you had the big idea that an infusion of a large amount of money, up to $500,000 over up to 3 years, what it could look like for you to make that significant change. And innovation in that, it needed to be something that was not occurring here in the region, or maybe had never occurred at all anywhere. And we were looking to support whatever that looked like. And so we had an opportunity to connect with ChildSavers a number of times through this significant, arduous elimination process, where really they were able to rethink what it looked like to access mental health services in the public school system. This was the complete wraparound with regard to social and emotional support for students, staff, and faculty. So recognizing the significance of adverse childhood experiences, the individual and collective trauma that was being experienced on a day-to-day before COVID, which we know has only exacerbated many of those issues, this was an opportunity to provide embedded training, coaching, and counseling for those students who are experiencing that trauma, and that training for the different staff and faculty to have the tools to be able to help children in recognizing signs of trauma, as well as having the tools to help children build that resiliency. We were jazzed by this, just knowing what that does. When a child is able to show up ready to learn, where they're able to be fed, be stable, that emotional stability and that impact on child development, what that was going to mean for impacting education and the ultimate trajectory of that child's life. That's what we were looking at doing there. We recognized that education was going to be the lever where we could mitigate a number of factors that would impact their economic mobility. We knew that there was this significant and severe life expectancy in the city of Richmond of 20 years. And it all was coming back to like the socioeconomic background of those children. And so by us investing in ChildSavers, partnering with them and their partnership with Richmond Public Schools, embedding this curriculum enhancement, consultation, parent engagement, and like directed clinical therapy, there was an opportunity to seriously change the direction of children's lives, better prepare those families so that they could thrive. I'm happy to go into some of those consequences later or answer some questions for you later, Debbie, but I'm going to defer to Robert now to talk a little bit more about the implementation and the program itself.
Well, first of all, thank you, Debbie. It has been about 100 years, it feels like, since we've known one another. And Courtney, thanks for turning it over to us. Well, the project that we partnered with Richmond Public Schools was pretty simple in its principles. How do we get closer to kids to provide mental health supports around social and emotional issues, particularly for those kids who were impacted by trauma? ChildSavers has been in the greater Richmond community for nearly 100 years. And most of our outpatient mental health work has involved clients coming to us. And strategically, we began to think in 2016 that the way to approach this problem is to get closer to where kids were. And the best way to do that, and the easiest avenue, if you would be the public school system. As we were thinking about that, the school system approached us and said, hey, we're educators, but we're noticing that many of our kids are showing up at school exhibiting behaviors that we have no sense of how to deal with. And we realize that lack of economic resources is a significant part of that. But what we're understanding more and more is that trauma plays a really important role here. And that trauma could look like anything from an incarcerated parent to abuse in the household, and particularly abuse against those kids. And the power of children is that many of those children, even though they had experienced significant trauma, showed up in school. And that was the first step. And we began to think about the challenge not as what was wrong with the children because they were exhibiting behaviors that were adverse, but what had happened to those children. And as a result of that conversation, Robbins came out with this new funding mechanism, and we thought, here's an opportunity to go forward and test a model to see if we could implant clinical staff inside of public schools. And at the same time, provide support for those who are working with our youngest children, the teachers, the administrators in school buildings, as well as the parents, and provide some engagement for those parents so they could better understand why children were showing up and not performing as well as they could in schools. And so the partnership started in 3 schools. We decided we're going to look at 3 schools that the school system chose because of academic performance was low in those schools. There was a lot of referral to the office for behaviors that were not great behaviors for the school setting. And there was a lot of disruption in the school because of these adverse behaviors. And so we started in those 3 schools. We implanted clinical staff inside of those schools, and in essence, provide outpatient therapeutic work for those kids inside the school building. Since 2016, we've expanded the program, and we're now serving 14 of the 40 plus public schools in the city of Richmond. And it is an exciting prospect because in the first years, we depended solely on the funding from Robbins and insurance reimbursement we got for serving the kids, because the majority of those kids were recipients of Medicaid services. And then as when COVID hit, the school system found resources through the CARES Act to provide some support for the program. So we had public funding, we had insurance reimbursement, which we call earned income, and then philanthropic help. Over the course of those 5 years, our work in schools will now exceed the work that we do in our headquarters building where we have our outpatient clinic. To give you a sense of that, ChildSavers 5 years ago was serving roughly in our mental health outpatient work somewhere between 400 and 500 kids a year. This year we expect to approach close to 800, and the majority of those kids that we serve will be in the public school system. We will be seen through our program in the public school system. To give you a sense of therapeutic sessions, if you think about them as events that happen within an hour or a fraction thereof, we expect to have therapeutic hours of roughly 15,000 therapeutic hours over the year. So our idea, we think the program is a complete success. We did have some challenges that we talked about in terms of recruitment and retention of folks, but particularly recruitment of clinicians of color. And when we started the program, we had no clinical staff of color who was working in schools, and now about 30% of that staff is staff of color, and also staff with Spanish language skills, which was an important piece because 2 of the newer schools that we're in were schools that had heavy Latinx populations, and we wanted to be able to serve those populations as well as we serve the remainder of the kids. So I'm gonna pause a little bit for now to open it up for questions about the approach that we took and why we took this approach and the work and what the work looks like. Debbie, is that okay?
Of course.
Okay.
Come on, there've got to be questions. I have a bunch myself, but I'm biding my time.
Debbie, I could probably help with give you a little insights on some of the challenges that we faced when we went into schools.
This is where I'm coming from. Yeah, you know me well.
And how we overcame those challenges.
Yeah.
And what we learned, one of the important lessons we learned was the association of our staff with the school staff. And in the beginning, we were seen as outsiders coming in to try to help. And over time, we learned that if we built the relationships with teachers, with counselors in the schools, and particularly the leader of that school, the principal. We were more successful in those spaces. And now when we go into a new school, we have a particular protocol where we start with developing the relationships with the staff in the school. And then we begin to go down, particularly the principal and assistant principal, and then go down to the classroom level and speak to the teachers. And what we learned is because our staff are inside of the school building, when teachers are thinking about issues that impact them, or they want to come and talk because they're exhausted, because they have been serving kids so long, trying to help those kids, that our staff is available all the time. And we have now been embedded in a lot of the staff meetings of the school itself to give ideas and feedback.
That's really great. Well, you know, Robert, what has it been like during the pandemic? You know, I mean, that's the thing I wonder about. Everybody wants to do stuff in the schools to, you know, bring different services in. You know, there's a lot of talk about school-based clinics and offering mental health services through them and that kind of thing. You know, what are you finding? I mean, are the schools ready to, I mean, have they regained their equilibrium enough that they could even contemplate something new coming in? That's the thing I wonder about.
Yeah, the answer is yes and no. So I'll try to expand on that a little bit. I think the pandemic was a shock to all of us, and I'll start with our agency. We actually went through an emotional full day of thinking and planning about whether we would keep our doors open or not when the state shut down. And we, because we were birthed out of the 1918 flu pandemic, we felt a responsibility to stay in this space and to be available to families and particularly to children. And so when we went into schools, there was this, during the pandemic, there was this nervousness because kids were at home, and how do we connect to those kids when they're at home? And so the advent of reimbursement for virtual therapeutic work was an important component of making sure that the work was continued. We worried about whether kids would have access to tools that they needed to do this virtual work. And because the school system had computers available and people had smartphones generally, we didn't see a tremendous fall off. There was some immediate, and then within a couple of weeks, maybe for about a month, we were up and running and really going to serve kids in school. But there were some particular challenges because the therapeutic work is private work, if you will, protected by HIPAA. And much of the time we had to navigate through having kids in a home space, if you will, that was not private. They didn't have a room that they could go to, or even in some cases, the perpetrator of some of the trauma against those kids were in the same space, if you will.
Right.
And so we had to navigate through a lot of that work. The big thing around isolation of children because they were separated from their peer groups became a huge issue for us. We saw an increase in suicidal ideation for some of these kids, and very young kids, 8, 9 years old, who were thinking about ending their lives. And so now we think the long-term effect of this is we will have programming that is a hybrid, where we will see kids in school and we will also see kids virtually. But it's an ongoing challenge to continue to convince families that it's important to address some of the mental health needs that we have. I think we've heard a lot about whether funding is available, and the reimbursement rates are an important piece of that, yes. I think in addition to that, it is ensuring that the kids who are on Medicaid, we have providers who can support them, and the paneling that takes place in the process and the timing of those, getting those clinical staff paneled is an important piece of the work that we do. I'm happy to say that ChildSavers did go through some time where we were looking for folks, but we're now fully staffed in our clinical work in schools and only recruiting for 1 or 2 positions in our outpatient clinic in our home building. So it's been a challenge systemically, but also in the important piece is building those relationships with school personnel to continue to work.
Okay, Valerie, we're at 3:25.
Yes, yes.
Are you bringing it home?
I guess I'm bringing it home. It seems like we've had a lot of great conversations about a lot of different initiatives. And of course, in everything that I hear, I always wonder how we can scale different initiatives up. And I think a lot of people alluded to that comment earlier today. Full disclosure, we also at Cameron have funded ChildSavers as well. And I'm always in the back of my mind, how do we scale up what it is that's happening now? So of course, Robert, just throwing out, wondering about the capacity. I didn't ask that question, but the capacity of the organization to keep pace, is also a huge question that we have to consider as well. So there, as we can see, there are a lot of questions, more questions than answers that we have around behavioral health. We want to thank everyone for joining us today. As another reminder, as Katie said before, please sign up for the conference. I know that you want me to give that extra plug. I think I need to sign up as well. So as a reminder to myself, thank you everyone. Have a great afternoon. Thank you to our panelists. You were absolutely amazing. You did an awesome job. And so
Yes.
we do truly appreciate your time today. Have a great evening, everyone.
Thanks, everybody.
Bye.
Bye-bye.